Today we have an external speaker visiting from Hamilton. Dr. William McIntyre is a cardiologist at St. Joseph's in Hamilton. He is also a population health research scientist at the Population Health Research Science Institute at McMaster University and an assistant professor of medicine. Dr. McIntyre is very well funded. He receives funding from CIHR, the Canadian Stroke Prevention and Intervention Network, as well as the CCS. He's published quite broadly, 165 peer-reviewed articles, including articles in high-profile journals such as JAMA, the Annals of Internal Medicine, Circulation, and the European Heart Journal. In 2023, he was the recipient of the Canadian Cardiovascular Society's Young Investigator Award. And his research interests include atrial fibrillation screening, medical therapy of atrial fibrillation, and treatment of new onset atrial fibrillation in cardiac surgery patients. Indeed, he is the founder of the Hamilton Health Sciences post-operative atrial fibrillation program. William lives in Hamilton with his wife Keely and his daughters Eleanor and his dog Rory. So we welcome Dr. McIntyre to Calgary, and this morning he's going to talk on improving stroke prevention at the ends of the atrial fibrillation risk spectrum. Dr. McIntyre, and welcome.
Thank you for the introduction, and thanks so much to everybody for having me, inviting me. Stroke remains the most devastating complication of atrial fibrillation, and in my short career, we've made amazing strides in this, but I think that there's still so much work to do and populations to be helped, and that's what I'd like to spend my time going over with you this morning. I wanted to take a moment to dedicate this talk to my late mentor, Stuart Connolly. It's not yet been a year since he left us, and Stuart's fingerprints are all over everything I will show you today, including the trials that he helped design that are ongoing now. So we wouldn't be here without him. These are my disclosures. So I've started to think a little bit about stroke prevention in AFib, kind of like an Oreo or a sandwich. And in the middle, in that creamy filling, that's our regular patients who have clinically apparent AFib that's manifested. It's been picked up by a surface EKG, and they've got enough CHA2DS2-VASc risk factors that it's a straightforward decision to offer them oral anticoagulation. But I think if you look at the cookie wafer parts of this Oreo, there's populations where there's really big remaining questions in atrial fibrillation, and that's what I want to focus on this morning. So the first is I call the low burden AFib, which goes into the device detected and the screen detected AFib. And let's unpack that first, leaning pretty heavily on our recently completed Artesia trial. So this is device detected atrial fibrillation. And if we ask ourselves the simple question, can I prevent strokes, or should I give oral anticoagulation for people with device-detected AFib? I think there's 4 questions we need to ask ourselves. 1, do these patients have a risk of stroke? Number 2, does oral anticoagulation work to reduce stroke? Is it effective? Is the actual risk high enough? And of course, is the bleeding risk acceptable? So I'll attack each of these 4 questions. So the first, are they at risk of stroke? So just to calibrate terminology, if you don't spend all your time in the arrhythmia and the stroke world, today we're using the term at the bottom, device-detected atrial fibrillation. This is something that's at the sort of the low or lower risk end of the spectrum that includes paroxysmal, persistent, and permanent AFib. It's AFib, there's no question about that. The questions are about the risk. It used to be called subclinical atrial fibrillation, the one above that, when we were wondering if it really was AFib. And AHRE is a term, mostly still European, that really just means that the pacemaker thinks it might be AFib and the doctor needs to confirm it. But now we've gone to device-detected atrial fibrillation because I think you'll all agree by the time I finish that what we're talking about is atrial fibrillation, and it's on the spectrum. So device-detected atrial fibrillation is super common, and it really simply just defines short-lasting episodes of atrial fibrillation that have not previously been detected by a surface EKG. And when I say surface EKG, I mean a 12-lead EKG, telemetry, Holter monitoring. And you can see here's a nice example of what we often see in the pacemaker clinic. This is on one of the device platforms. The nice blue tracing up the top is what the atrial lead is seeing, and it's seeing that chamber go fast and erratic. And that green or red one on the bottom, I'm colorblind, is how the V responds. So we can see that's clearly atrial fibrillation. What it means for the patient is what the question is. And this is super common. Over the lifetime of having a device, about 1 in 3 patients will have this during their time. And my mentor, Dr. Healy, with Stewart, showed in 2012 at ASSERT that this was clearly associated with an increase in the relative risk or hazard for stroke. So they took people who had device-detected atrial fibrillation and people who didn't, and then over follow-up of about 3 years, the hazard for stroke was 2.5 times. So if your pacemaker picked up this short-lasting atrial fibrillation, your risk of stroke was 2.5 times what it was if you didn't. But here's the catch. That was a relative risk. This is what it looks like at absolute risk. So the blue bars here are people who have no atrial fibrillation at all. And then the red ones are the garden variety clinical atrial fibrillation. In the middle, with an intermediate risk of stroke, is the white ones, people who only had device-detected subclinical atrial fibrillation. Here they're stratified by by their CHAD score. So you have a population with an intermediate risk where you have to ask yourself the specific question, are the risks and benefits of oral anticoagulation justifiable? Now, when ASSERT was recut a certain way, it was cut by the longest episode that the patient had over follow-up. So there's a cool analysis, was called time-varying covariates. That just means that you carry a duration variable with you, and then as soon as you hit a longer duration, you're just in a different bin. And what we saw here was the risk in ASSERT was driven by patients who had a longest episode of 24 hours. So this golden color that I have here at the top, those patients had an annual risk of stroke of 3% a year, which is up and away high enough to justify oral anticoagulation for just about everybody. So we ask ourselves the question, what do we do between 6 minutes and 24 hours? So I think that I've clearly shown you that patients with device-detected AFib are at risk of stroke. The question is, does conventional oral anticoagulation reduce the stroke risk? So to do that, we performed the Artesia trial. So Artesia took patients who had a pacemaker, ICD, or a loop recorder and had subclinical device-detected atrial fibrillation with the longest episode lasting between 6 minutes and 24 hours. And then they had to have something in the red for the CHA2DS2-VASc enrichment factors. They were randomized to either apixaban or aspirin. The reason that aspirin is the comparator in this population is because the majority of patients in this population are on aspirin at baseline. I understand the role of aspirin in stroke prevention. And of course, the primary endpoint was stroke or systemic embolism. When I say stroke, I mean all-cause stroke. And the primary safety endpoint, of course, was major bleeding. There were 4,012 patients that were enrolled globally in this trial, and that includes 37 here in Calgary by the fantastic Dr. Mitch and his team. And if you're not familiar with clinical trials, enrolling 1% of the global sample when there's 250 centers is an awesome performance, and I think speaks very well to your capability of how the site could contribute. So these are the top lines results. So put simply, apixaban reduces stroke in patients with device-detected AFib. On the top in red, you can see that risk of stroke in aspirin-treated patients was 1.25% per year, compared to 0.78 in blue on apixaban. We'll come back to those numbers. The hazard there in the top left, 0.63, 37% relative risk reduction in the hazard of stroke. Now, if you know the literature, you know that there was another trial that came out just a few months before Artesia. It was called NOAA. The top line result looked a little different, and I'll unpack that for you. But we published a systematic review and meta-analysis at exactly the same time, showing you in the top forest plot that very clearly ischemic stroke is reduced in this population by oral anticoagulation as compared to aspirin or placebo. And of course, on the bottom, that these treatments also increase the risk of major bleeding. So I think it's worth taking a quick peek at the NOAA trial, which came out just a few months before Artesia. And I told you that the primary outcome of Artesia was stroke or systemic embolism. Now, the primary outcome in the NOAA trial that was negative at the top line was cardiovascular death, stroke, or systemic embolism. And I criticized that choice of a primary endpoint quite heavily. So if you look at this slide right here, right, I've gone and I've highlighted for you what I call DOAC responsive conditions, right? If I'm going to give a patient a blood thinner, what sort of outcomes do I expect to decrease? And then you would ask yourself the question, patients with AF, what are their mechanisms of death? So I've highlighted for you, right, myocardial infarction, ischemic stroke, right, and hemorrhage. All of the conditions that you think would change by giving a blood thinner that range between 15 to 33% of all cardiac and vascular deaths. And I think the consequence of doing such thing is that you dilute the effect of oral anticoagulation when you already have stroke in your composite and you put in cardiovascular death. Why? Because you look at the biggest things that are there. Sudden death and heart failure are the number 1 and 2 causes of death in patients who have atrial fibrillation, and one should not expect oral anticoagulation to reduce those things. Nevertheless, you could see on the bottom here, when we did meta-analyze NOAA and Artesia together, there was just enough power to sort of overcome that handicapping, if you will, of having a diluting endpoint. And overall, there was a 15% reduction in a composite endpoint of stroke, embolism, or cardiovascular death. So, to the question, does oral anticoagulation reduce stroke in patients with device-detected AFib? I think I've shown you clearly yes. The next question, is the risk of stroke sufficiently high enough to justify oral anticoagulation? This is where I think this gets controversial, but I do think the answer is ultimately yes. So if we ask ourselves, what's the annual rate of stroke that justifies oral anticoagulation? What's a low risk of stroke? Well, there's a couple of ways to come at that. So the classic approach, or one of the first ones, was just to use a Markov economic simulation model where you run probabilities over and over and over again, right? At what annual event rate do the trade-offs for bleeding become justifiable? And this is actually published in 2011. It's still cited by every guideline, but you can see, as I've put in the light green there, 0.9% a year of an annual stroke risk. That's what economic models showed us long ago was the rate of stroke that would justify any effects of bleeding. And that actually shakes out still in the guidelines that we see today. I'm not going to show you the Canadian guidelines because they're now a few years old, but these are the 2023 American guidelines. On the top, they say if your annual risk of stroke based on the CHADS-VASc score is higher than 2%, that's a class 1A recommendation for oral anticoagulation. Oh, you're running away with it. If your annual risk of stroke is between 1 and 2%, that's where they sort of have a 2A. That's the you should consider this sort of a phraseology. And if you look, the Europeans are saying exactly the same thing with some different phraseology. So based on a CHADS-VASc score, dropping the sex category, they're giving a class 1 recommendation if the score is over 2, and elsewhere in their guidelines, they tell you that that's an annual risk of stroke of 2 or more. And they have the same, a class 2A, if that risk of stroke gets over 1%. Now, what I think is a little funny is the Europeans also made a guideline statement that if you have only device-detected atrial fibrillation, they drop you down to this 2B for a may be considered. But I don't think that makes any sense because I'm going to show you that the risk associated with most device-detected atrial fibrillation is between 1 and 2%. So I think this is a very questionable recommendation, and the guideline document is actually not internally consistent with itself. But they didn't invite me to the panel to fix it. So I'll show you here in this table that the rates of stroke in device-detected atrial fibrillation, they exceed 1% per year. So in the top, that's the Artesia trial. I've circled all the outcomes of stroke and ischemic stroke. You can see that in patients on aspirin, the annual risk of stroke exceeds 1%, ranging from 1 to 1.2 there. And then in NOAA on the bottom, the rate of ischemic stroke was 1.1% overall in the placebo aspirin arm, which was actually dominantly aspirin. So this population is clearly getting into that 2A sort of a zone. So question 3, is the risk of stroke sufficiently high to justify oral anticoagulation? I think, yeah, it's controversial, but I think that the answer here, if you really look at the numbers and you really look at how we've anchored the rest of our clinical practice, is yes. And then the question, is the bleeding risk acceptable? So I think it's important to look not just to say stroke and bleed and to say that these events are equivalent, but to look at what these events actually mean for patients. So what I've shown you here is results from our TEASIA where we actually looked at event severity. On the top is your stroke event severity. And what I've circled there in green is a modified Rankin score of 3 to 6. This is your level of function 90 days after a stroke. And if you're 3 to 6, that means that you were disabled, okay? And on the bottom, we actually, I believe for the first time in a clinical trial, adjudicated the course and severity of major bleeding. And you can see that the minority of bleeds on patients, in patients were actually these red category, which were death unavoidable. And if you look at the numbers, you could actually see that bleeds on aspirin were more likely to kill you than were bleeds that were on apixaban overall. So the event severity is tipped a little bit in favor of the strokes. The other question is, you know, we've seen this song and dance before. We've been doing oral anticoagulation trials since probably around the time I was born. And we've always been looking at stroke and at bleeding. And what I've put before you here is the rates and the relative rates of stroke and bleeding on the top, circled in blue, in the 4 pivotal NOAC trials, and in the bottom in the device-detected atrial fibrillation trials. So in yellow, you use my thing, I've shown you the stroke-bleed ratio. So depending on the clinical trial you've looked at, the rate, crudely, of strokes to major bleeds has been between 1.2 and 1.3 in the DOAC arms and clinical trials across the board, okay? We are used to seeing more bleeds than we did strokes. And if you look, highlighted in light blue is the annual rates of major bleeding on oral anticoagulation in all these trials. And you'll see in NOAA, that was 2.3% per year, and apixaban, that was 1.7 per year. Those rank number 4 and number 6 all time in terms of bleed rates. So these patients actually bleed less too. We're used to seeing patients bleed more than they stroke, but the subclinical device-detected atrial fibrillation patients have actually tended to bleed less than the full clinical atrial fibrillation patients. And then the other thing that's important is who experiences the stroke and the bleed? Well, it's the patient, right? And old research, actually done mostly in the warfarin era, showed that patients, particularly as compared to doctors, put more emphasis and value on stroke prevention than they do on bleeding. PJ Devereaux showed that 25 years ago, and Steve LaHaye did simulation experiments to show that the trade-off is about 4 to 1, meaning most patients are willing to accept 4 major bleeds for 1 stroke. So you have to get at patients, you have to have conversations with them. We're repeating some of this work with the subclinical atrial fibrillation numbers, and Ruby Sandhu is going to lead that locally because we're doing kind of a global survey because it's really about what patients think when we give them the numbers. So to summarize this, and if you're a picture taker, this is a good one for your take home. Are patients with device-detected AFib at risk of stroke? I think yes, absolutely, and the evidence is consistent. Does oral anticoagulation reduce stroke? Yeah, there's high-quality evidence from 2 RCTs that are completely concordant when you're making sure you're asking the same questions. Is that risk of stroke high enough to justify oral anticoagulation? Well, the risk is above 1% per year, and this has been shown to be meaningful by patients, guidelines, and economic models. And is the risk of bleeding acceptable? Well, I think to many patients it will be, right? Oral anticoagulation is preventing fatal and disabling strokes, mostly at the expense of non-fatal bleeds, and patients actually tend to value that more. So I think that's the way it shakes out. Of course, not everybody's going to see that the same way for every patient. And after we published these trials, we got the call for editorials, right? Great debate. Should device-detected AFib be treated like clinical AFib? Should we anticoagulate or not? Should we receive anticoagulation? What are the decisions to make? And then I think this one was towards more personalized management of device-detected atrial fibrillation. No doubt, when you have a treatment that has both an efficacy and a safety signal, there's going to be appropriate calls for refinement in populations. So if you look at the 2023 AHA American guidelines for atrial fibrillation, and the European ones have something similar like this, they tell you to look at this atrial fibrillation on a 2x2 sort of axis, right? So the x-axis here is the patient risk, which is just the CHA2DS2-VASc score, and then the y-axis is the amount of time you spend in atrial fibrillation. Now, you should think about this mostly qualitatively. The higher CHA2DS2-VASc score, the more likely you are to anticoagulate. The longer they're spending atrial fibrillation, the more likely you should be to anticoagulate. But they did try to draw some lines in the sands and have inflections in colors. So these are the things that we targeted in early subgroup analyses. So I think of all of them, this is probably the single most useful one. This is the risk of stroke and bleeding divided according to the patient's CHA2DS2-VASc score. So we did CHA2DS2-VASc score below 4, 4, and above 4, which corresponded to sort of rough tertiles. And if you look at the forest plots that are there in the top right, you'll see first for stroke systemic embolism that the higher your CHA2DS2-VASc score, the higher your rate of stroke. And those are actually absolute risk differences. And then on the bottom is really major bleeding, which really does not vary very much with the CHA2DS2-VASc score. And if you bubble these things down together, I think you can get to sort of the stoplight approach. In green, if your CHA2DS2-VASc score is less than 4, you have a low risk of stroke. And for most of these patients, probably the bleeding risk outweighs the benefits. On the far right in the red, if your CHA2DS2-VASc score is greater than 4, you have a high risk of stroke, and the stroke benefit certainly outweighs the risk. And then in the middle is sort of the yellow, where things can kind of go either way. So certainly a very strong, I think, impetus or rationale for oral anticoagulation with a CHA2DS2-VASc score of 4. Subgroup that's super helpful, and this is freshly published last week in Lancet Neurology finally, is patients who have device-detected AFib and prior stroke. They're more likely to benefit from oral anticoagulation. So on the left, right, about 10% of patients in Artesia had a prior stroke, and no, they're not well phenotyped, right? And I think that that's a limitation. But for those patients, oral anticoagulation reduced the risk of stroke. And if you look at the absolute risk reduction, the number needed to treat to prevent 1 stroke in 3 years is about 15 or 16, which I think is pretty powerful and I think speaks very strongly to offering oral anticoagulation to people with device-detected AFib and prior stroke. What it means about somebody who has prior stroke, has no AF, and if you have a loop recorder to put in, I think is a totally different question, but I think that this can help you how to handle that. The other one that's a little bit weaker maybe, but I think still goes in the right direction is a combined estimate we did with NOAA based on whether or not the patient had vascular disease, right? And one way to think about this is an indication for aspirin to begin with. So we found that patients who had vascular disease overall had higher rates, and then maybe the overall picture tended towards favoring oral anticoagulation for them. Although I acknowledge that the interaction subgroup p-value, if you're a purist, is not statistically significant. What doesn't help? Duration. This is the one that I spent all my effort on personally and didn't shake out, but that's okay. So we divided patients at baseline in Artesia according to the length of their longest episode. We chose less than 1 hour, 1 to 6 hours, and 6 hours. And we did that for 2 reasons. 1, people have floated these time cutoffs before. And 2, it kind of gave us rough tertiles in the population. Here you see the absolute risk of stroke according to the duration of the longest episode. And there's really no difference. Everything clusters right around 1%. So that duration parameter, like I showed you initially in that American guidelines panel, is not useful for helping patients. What could be useful is one of the measures of frequency. On the bottom is patients who had a few episodes versus a lot of episodes, because that's what the pacemaker tells you for the story over the last 6 months. Again, their risk all clustered around 1%, so there was really no difference. What is actually a hypothesis generating, and is on the top here, is if you didn't have atrial fibrillation on your device in the 6 months before getting into Artesia, those patients appeared to be lower risk, right? So those patients did have atrial fibrillation at some time in the remote past, just not fresh. You could say it went dormant. That's something that we need to look at specifically. And none of these things show any difference in treatment effects. Age is something that's really important to look at. So these are splines, and you could see they're pinched down in the middle. That cluster's right around 70, 75, which I think is an artifact of how the CHADS-VASc score modified the inclusion criteria. But otherwise, for the most part, what you're seeing with this graphic is risk just going up from left to right, and the treatment effect staying consistent. So age, the higher your age, the more likely to stroke, the more likely you are to bleed, but oral anticoagulation is not going to change qualitatively with its interaction with you based on that. And then major bleeding, right? Major bleeding is almost a straight line going up with the treatment effect being consistent all across the board. So higher risk the older you are, but no difference in the way that oral anticoagulation affects you. So I think when it comes down to oral anticoagulation for patients with device-detected atrial fibrillation, I think this is another take-home slide. That baseline risk-benefit could be acceptable to everyone, and I think it behooves us to at least discuss it with any given patient. Don't worry about frequency and duration for your stratification. Do know that as age goes up, the likelihood that they're going to have an adverse event goes up, but the interaction with oral anticoagulation doesn't change. And under bullet number 4, I think that's what's really useful in decision making. For people with low CHADS-VASc scores, probably the risk actually outweighs the benefits. For 4, I think you're going to have to discuss, and I get that that could be a challenging conversation. If your CHADS-VASc score is 5 or up, then the benefit really outweighs the risk, and I think it's a straightforward go for it. If they have a prior history of stroke, the benefits far outweigh the risk, and I think that that's a straightforward go for it. And then patients with vascular disease, right, and an indication for aspirin to begin with, most of those people, I think, end up sort of in a go for it. So going back to the cookie, right, we talked about how the frosting has been handled. We just dealt with the top layer of the sandwich. And this is where a lot of the field is going now, and is atrial fibrillation patients who have a high residual risk of stroke despite oral anticoagulation. So this is a graph from the Combine AF group. And Combine AF is just the 4 pivotal DOAC trials, Aristotle, Rocket, Rely, and Engage TIMI, all lumped together in a combined database. So it's the largest DOAC database there is out there. And what they did in the Combine AF database is they just looked at the rates of stroke in people who were taking their oral anticoagulation. And here the curves are stratified by what the CHADS-VASc score was and whether you had paroxysmal or non-paroxysmal AFib. What I'm calling out to you there in the yellow at the top is patients who had a CHADS-VASc score of at least 4 and had persistent or permanent atrial fibrillation. On oral anticoagulation, our standard of care therapy, their annual risk of stroke is 2% per year, right? And remember, 2% is a big number. 2% is the annual risk of stroke that makes oral anticoagulation itself a 1A indication. So this is a huge ongoing problem and a leak in the system because there's a lot of patients around that are like this. Another group that's very high is this is patients, and the big division here is according to whether or not they had a prior risk of stroke. So the yellow line there is a CHADS-VASc score of 4, prior stroke, right? Atrial fibrillation, and the pattern doesn't matter. Their annual risk of stroke, so even higher, right? And again, this is a breakthrough stroke despite being compliant and adherent and taking your DOAC. Now, the good news is that we've shown therapies can actually work in this population, right? So this is cardiac surgery data. This is the left atrial appendage occlusion study 3. And this is the, I'm doing cardiac surgery on my patient. They have AF. Well, I'm in there. Why don't I snip off the left atrial appendage and see if it prevents strokes, right? And of course, it showed by and away that it does, right? The hazard ratio is 0.67. So on top of oral anticoagulation, they were able to reduce stroke by about another third. And where I'm going with this is I'm going to suggest that we study percutaneous left atrial appendage occlusion. But let's look for a second deeper at surgical left atrial appendage occlusion. That effect is diluted by early perioperative strokes. So you can see overall that hazard ratio is 0.67. But when you do a landmark analysis, and landmark analysis just means you take time 0, right? So before 30 days is there in red. That's only strokes that happen in the first 30 days. And then green is you just start the counter at 30 days. You could see that the stroke prevention power manifests itself beyond 30 days, right? Around the time of cardiac surgery, there's perioperative strokes, the etiology of which is often a little bit muddy, unclear, and ultimately probably provoked by surgery. So to suggest that if you did not have the early postoperative period in this data, the effect could be even more powerful. And in LAOS 3, patients were to stay on oral anticoagulation, right? That's the way it was designed. Obviously, people do come off. It was about 77% of people that stayed on throughout the trial. And this is, I think, a really neat analysis that uses, again, our friend, the time-varying covariate at each visit to look at whether patients are staying on their oral anticoagulation or not. And then over in the far right column, you see the hazard ratios for treatment, right? The bottom one is not on oral anticoagulation. And those two hazard ratios are very similar, which suggests that the stroke prevention power of left atrial appendage occlusion operates independently to oral anticoagulation. Said another way, the stroke prevention power of the two drugs together could be additive. So based on this, we designed the LAOS 4 trial, right? And I want to be crystal clear here. We are testing left atrial appendage occlusion on top of oral anticoagulation, right? Most patients around the globe right now are getting this treatment as an alternative. This is being studied as a combination therapy, okay? So everybody in this trial is meant to take their DOAC for the duration of the trial. So we've got 4,000 patients with AF, and the groups that's in there are the ones I showed you in the early graph. People who have CHADS VAS score of 4 and have either persistent or permanent atrial fibrillation, or their AF is paroxysmal and they've had a prior stroke. It's a simple randomization to oral anticoagulation plus left atrial appendage occlusion with the percutaneous Watchman device, or just oral anticoagulation. Why are we doing this? Of course, to prevent stroke. So the primary outcome is ischemic stroke or systemic embolism. We are doing this at 200 sites in 15 countries, including right here in Calgary. The goal is meant to enroll over 2 years and follow up over 3 years. And if you think about, right, our AF population, we deal with a lot of people where rhythm control has had its resurgence, so that has a lot of our focus now, but there's a ton of people floating through all of our practice and interacting with us who could have their stroke prevention regimens optimized. Some sites in the world have been incredibly successful looking in their pacemaker clinic, where patients are usually of a rate control mindset. They already have a device, right? And they frequently have oral anticoagulation. The idea of a left atrial appendage occlusion is acceptable to them. In general cardiology clinic, there are many more patients that are older and often comorbid that are getting rate control. Of course, our stroke neurologists every week are seeing patients that have a stroke and AFib is diagnosed, and the even more unfortunate population that is having the breakthrough strokes. And all the time we're looking at patients for going for cardioversion. So there's patients everywhere that are floating around for this. And I've spent a lot of time talking to people about why they would want to do this trial. And we remind them that your risk of stroke, if you're eligible for this trial, is 10% in the next 5 years. I think that by most measures, that's quite big. And we think left atrial appendage occlusion could drop that 40%. Anticoagulants are great drugs, but they're not perfect, right? We have to stop them for procedures. Sometimes people do have bleeding. Sometimes there are interactions. Sometimes you just forget your pills and don't make it to the pharmacy. Left atrial appendage occlusion now is a one-time procedure, takes about 60 minutes, has a very, very low complication rate, and is highly successful. The kinks of the procedure have been worked out. And if we think about our frame and mindset, in thrombocardiology, we've been doing combination medical and mechanical therapy for a while, right? You do PCI, you get a stent, you take dual antiplatelet therapy, and then you step down to single antiplatelet therapy, right? If you have a stroke, you get an endarterectomy. You have your carotid scooped out, but you continue on antiplatelets. Coronary artery bypass grafting is the same thing, right? So combination therapies very much in vogue. So to conclude on this is that many patients with paroxysmal persistent permanent AFib still have a high residual risk of stroke on oral anticoagulation. And then there's an urgent need to help them. We have a good theoretical basis that occluding the left atrial appendage may offer incremental stroke protection on top of OAC. This has absolutely been proven with the surgical approach, and it's time to test it in the LAOS 4 study. So here in Calgary, the local PI, Steve Wilton, Jen's the research coordinator. They're happy to hear about patients by email or this thing you have called epic tagging. And I'm sure that you guys can help us answer this question for our patients going forward. Thanks.
Very much for that. We'll open the floor to questions.
At least one in the chat.
There was there already, so
Yeah.
We'll just open up the chat box. So why don't we start in the chat there?
Carlos's iPhone. Oh, it's good. AI is asking the questions now. So should the ASSERT sub-study documenting that greater than 24 hours device detected AF should be tossed out of the guidelines? Or is this still useful based on Chad's VAS score greater than 4? Yeah, so I think that the mantra, and we've got a paper on progression, if you have device detected atrial fibrillation and it lasts 24 hours, just plug that into the pathway for clinical AF, right? It's essentially the same thing. Those patients respond, and the stroke risk stratification for those people work the same. The Chad's VAS score 4 is when your longest episode is not yet 24 hours. And I didn't show it in this deck, but we've shown well in Artesia. We showed it at ESC, and we'll finish the paper one of these days, that over the course of like 3 years, 30% of people who have device-detected atrial fibrillation are progressing. So their phenotype is always changing, right? The nice benefit of that is at pacemaker clinic, we always have structured follow-up, usually at 6 and 12-month intervals. But for people that have past device-detected atrial fibrillation and maybe have not made an oral anticoagulation commitment, they need to be re-stratified at each visit, because very frequently they are going to turn over and basically become a regular clinical AF patient. Doc.
Any questions?
Yeah. Yeah. Mm-hmm. Yeah, yeah. So I think you make it. Yeah, absolutely. So Dr. Hill has asked about the reasons that people might have breakthrough strokes when they have atrial fibrillation and have taken oral anticoagulation, right? So I think that you could name them much better than me, all the competing like risk of stroke mechanisms, right? Because in the grand scheme of things, the population attributable risk for atrial fibrillation to stroke is like 15-20%, depending on how you do it. And, you know, there's small vessel strokes, large vessel strokes, all those sorts of things. So why they failed, it could be because of, you know, DOAC compliance. There's not the granularity in those data sets to go back and look at a lot of that sort of stuff, right? Those show that the event rates are high, right? But it is completely compatible with, you know, LAOS 3, and that I showed you that left atrial appendage occlusion on top of oral anticoagulation provides sort of incremental benefit, right? So yeah, so it's hard to, yeah, it can be hard to pick apart, you know, what's what, and that's why it's not going to be 100%, you know, stroke reduction, because not every stroke, not every ischemic stroke in a patient with atrial fibrillation is a cardioembolism. So, yeah. Yeah. Hmm. Hmm. Yeah. 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 There'll still be work to do, right? And like there's going to be a residual risk of stroke beyond that. And yeah. Yeah, yeah, since imaging has evolved, right? Like one of the biggest challenges with Artesia is it ended up, with the pacemakers were not all MRI conditional, and it's also when you the expense of a big trial like that to go and phenotype people and stuff like that. And one thing in Laos 4 that we're trying to make an effort in is we expect about a third of our patients to be recent stroke patients, and we're trying as good as possible to try to deeply phenotype the qualifying stroke, and then of course the one after that to try to pick those things apart. But uh-huh. Hmm. There's big clots and there's little clots. Yeah, yeah, yeah. Yeah, no, exactly. And there are other like mechanical trials that I haven't shown, like Intercept puts filters in your carotids to try to do that, right? And they would obviously, yeah, may or may not. It'll pick up smaller debris. Well, somebody's testing it anyways, right? So we'll see, right? And that's the challenge is you come up with theories and then you have to put a treatment in a trial, you reduce, and then yeah, then you take things from there. But no, there's always going to be other competing mechanisms and things. And I think it also speaks to walking back. There's in the post cardiac surgery world now, they're doing a trial of people who've had left atrial appendage occlusion, and they're actually stopping their oral anticoagulation and going for non-inferiority, which I think is it's a whole nother talk, and we'd have to put some Baileys in our coffee to be able to get through it. But then the margins get funny. But I think that it's really, really important to be framing this as combination therapy rather than substitutes, right? So, um, yeah, absolutely. Hi, Jacques. Jacques says, how do you think Artesia would have looked if you had a control group that was not on aspirin? We have a large group of patients that fit this description. The severity of bleeds will for sure be lower than those on aspirin, and it would make the risk of bleeding out of Paxaban more concerning when comparing the benefits. Yeah. So you may have ended up with results similar to the NOAA trial. So yeah. So if we go back, right, and maybe I can go back in my slide deck, Jacques, to show you, because we did meta-analyze that, right? And if you look at ischemic stroke in NOAA, it was just an underpowered version of Artesia, right? Here, we'll look at this one here, right? So you can see the top fluorescent plot. That's just ischemic stroke. And remember, NOAA, if you read the top line, it'll tell you it went against placebo. 54% of patients in the NOAA trial were on aspirin in the placebo arm, right? So they've disentangled a little bit of their data, and I think that's when they came to us looking at the indication for vascular disease. So I think the two takeaways from that are yes, absolutely, you would have a greater effect on stroke right? And you would have a larger effect on bleeding, right? So both effect sizes, I think, would magnify kind of in opposite directions that way. And I think that's where you just really have to frame the discussion. The patients that truly have a CHADS-VAS score, if you make it to a CHADS-VAS score of 4 with device-detected atrial fibrillation, usually prior stroke or vascular disease has slipped in there, one way or another, so they usually do end up with an aspirin indication. So we can't say for sure, and that would be almost an impossible trial to do. We are working with NOAA to build an individual participant data meta-analysis so that those sort of questions can be drilled down on. It's very, very hard to do at the trial level just to the way that characteristics aggregate, but I think that's something that we're very interested in too, because framing the decision between oral anticoagulation and nothing versus oral anticoagulation and aspirin are two different things. I agree. Mm, yeah, yeah. I think that's a good question, right? Because then you have to say, what's the incremental cost? What's the incremental risk of an atrial lead on top of things, right? I know that well, Satish isn't here, but he tells me he really likes VDI pacemakers, right? And things like that. I think that's a challenging, question to sort of answer that way. I think that the pacemaker will obviously give us other clues in follow-up, right? That, that they're going to have, oftentimes, depending on the indication, ventricular high rate episodes that may lean that way, right? So I've never thought about that way, to be honest with you, because it's, yeah, no, for sure, to ask the tough questions. Because it's a couple of, I don't want to say leaps of logic, but it's a couple of steps of logic. So, yeah, it's a good question.
If anyone wants to put another question in the chat, please do so now. And anything else in the room? While we have a second, do you want to just go over the allowance?
Yeah,
So
absolutely. Yeah. Let me put that slide up again. Oh, here. Wait. There. So you can take a picture of that if you want, right? So the number one is to remember CHADS-VAS. If CHADS-VAS score an AF, right, is probably worth time that, Jen can do the filter on the pattern, right? So if it's paroxysmal AF, they have to have a prior stroke. And if it's not, if it's persistent permanent, they don't have to have a prior stroke. But AF and CHADS-VAS score will help you to start thinking about it, right? And again, it's that condition reflex of AF rate control patients usually end up leaning towards eligible for this. Yeah. And it's not a case. It does not matter. So it's a paroxysmal AFib and prior stroke, regardless of what they were on at the time of the stroke. Yeah. 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 If somebody like you wants to call that a stroke, we'll take them. Yeah, that's the goal, is to make it generalizable, because those are the two things that bring it up. Dr. K, do you have your hand up? Yeah. Why not a surgical arm? Yeah. Yeah, so that's a great question. We're doing that in a separate trial. It's called LEAPS. So LEAPS is taking patients who are having cardiac surgery that do not have atrial fibrillation, actually, and have some CHADS-VAS risk factors, and they're going for prophylactic left atrial appendage occlusion that way. To go head-to-head here, like I don't know if any surgeons here do thoracoscopic left atrial appendage like implantation, right, or occlusion. We've done that a few times in people that have, access issues, or like if a patient has an AVM in Hamilton and we just decide they need left atrial appendage occlusion, we'll do it thoracoscopically, because then there doesn't even have to be a short-term commitment to some kind of an intense antiplatelet regimen. But I think it would be ultimately, generalizable. And the other thing is, Boston Scientific is paying for it, so that's the other reasons this way.
Very much, Dr. McIntyre. That was
thanks so
wonderful
much for
talk,
having me.
and thanks for coming out to Calgary.
Hey.
Okay.